All right, so it's 6 o'clock. Everybody, welcome to the next edition of Virtual Global Spine. I decided so I'll be hosting tonight's talk, and I wanted to do something a little bit different, something that was a little bit geared more towards residents and fellows and early career attendings. Kind of give you some advice. I myself am an early career attending. I'm in about to be in my fourth year of practice. I'm a neurosurgeon by training. Did most of my training in New York City. I did my fellowship in the Cleveland Clinic, and then ultimately I returned back to New York City, and my practice is in New York City. Um, and I felt that during this time, it's very hard to get good advice, and it's hard to have people who can kind of guide you through not necessarily how to get a fellowship and how to do surgery in the OR, which is obviously very important, but like what happens afterwards? Like how do you plan your life? What do you do about when you graduate? What do you do for a job? What do you do for contract negotiations? No one really tells you this stuff. It's hard to get really good advice, and I'll say that the main thing, obviously, I'm going to give you, I'm going to tell you kind of a little bit of my experience and give you some pearls and things I learned along the way because I'm still pretty early career. But I would say really one of the best things at the end of the day is to find somebody who can be a mentor to you, who can really kind of help you and show you some of the strengths, So everyone's going to have a different path, right? But at the end of the day, there's some certain key principles that stay the same. So let's jump into this. And I want to keep this kind of interactive. So if you have any questions, please go ahead and just type them in the chat box, and I'll be happy to answer them. We'll take little breaks here and there. So I really want this to be interactive. So please ask questions. Let me know if there's anything you want to talk about. If something doesn't make sense or whatever, I'm happy to clarify. So let's just jump right into it. So um, so basically, if you think about how you're going to break this up, right? Your career, whether you're orthopedic spine or neurosurgery spine, is going to be residency, fellowship, then you're an attending, then while you're an attending, you typically will get board certified, and then usually that's oral boards, because you take your written boards during your residency, and then after that will be, and then this is what happens when you're an attending, really, but actually occurs all throughout your life, but becomes much more pertinent as an attending is your family life and career advancement. These are things you're gonna have to think about. So I want to, again, I kind of mentioned this before, but again, everything I'm going to be talking about, these are all my personal opinion. All the experience I got, all the advice I'm going to give is my personal opinion. Kind of distilling and interpreting all the things I've seen since I've been through this process and have been through it very recently. And this is really primarily aimed towards United States residents, fellows, and attendings. I'm sure the vast majority of what I'm going to talk about is applicable in any setting, but this is really more geared towards that. And also through the spectrum of neurosurgery training, because that's my background. I went to ChatGPT and I typed in um, um, what do you think is interesting about spine surgeon? Or can you think of a question you'd ask me? And ChatGPT asked this. It says, what sets the journey of a spine surgeon apart? And I kind of like that because I couldn't answer that easily. And I felt like I could just answer that off the cuff. And I'm going to return back to this question because I think that our path is very, very unique. And I'll go a little bit more into that, but more so than the other, and again, this is through neurosurgery, but through the other subspecialties of neurosurgery, we have a very unique path. And it's rapidly changing over time, as you will see, and I'll allude to. But starting from the basics, residency, right? So what is the difference between the residencies, right? So you have essentially to become a spine surgeon, it's either you go through neurosurgery or orthopedic surgery. The main difference is once you're an attending, there's really no difference, right? But when you're a resident, there's a difference in terms of training. So a lot of med students ask me, oh, I want to do spine. I like spine. Should I do ortho or should I do neuro, right? And I say, my response to that is, well, there are a lot of differences between the two. It's not that easy. But if you're going to kind of break it down to what are the fundamental differences between neuro and ortho when it comes to spine are the following. Neuro trains longer. It's about 7 years. We have earlier exposure to spine that's more predictable and consistent. Typically, you're in the OR, like your first day in the OR, you typically do a spine case, right? With orthopedic residencies, it depends on the program. And it depends on, in many cases, your chiefs. Like sometimes, yeah, you do have spine cases, but if you have a chief who wants to do spine, he's going to take all those cases. So you may not even be able to get that experience until you're much later in your residency. So it's kind of variable between program. It's a little bit unpredictable. What if an attending leaves, right? What are you going to do? What if sometimes the cases are shared, like in Cleveland Clinic, the orthopedic attendings and the neurosurgery attendings are covered by both neuro and ortho residents. So maybe a neurosurgery resident takes that spine case. You don't really know. It depends on the program. Um, with fellowship, right? Uh, it's generally expected if you're going to do spine as the bulk of your practice as an attending, it's expected to do a fellowship. It's not required in neurosurgery, but it's definitely required. It's definitely expected. You're expected to do a fellowship. With orthopedic, you pretty much have to do a fellowship. I can't think of it's pretty much required. And then in terms of board certification, and this is once you graduate and you've been in practice for a couple of years, you with neurosurgery, you are taking general neurosurgery oral boards. So you're still going to be talking about, tumors, trauma, in addition to spine. Now, in the past couple of years, they have changed the oral boards to be more specialty specific. So you can actually take a more spine-oriented neurosurgery boards, but you still are going to be studying for general neurosurgery versus orthopedics. You take spine boards. You are becoming a board certified spine surgeon. So it's definitely geared more towards spine. What's nice, I'll say generally, the way I think about it is like, if you go through the orthopedic route, it's less time, but you're going to pay for that later as an attending. You probably, there's going to be a little bit more mentorship when you're attending, more oversight. But eventually, it will reequilibrate with that with the neurosurgery. But what's nice about doing the orthopedic route is that you're a spine surgeon generally. It's rare that you'll have a orthopedic surgeon doing general ortho and spine. I mean, that does exist, and it's not rare, but it's fairly uncommon. Generally, most orthopedic surgeons are just doing spine. You're a spine surgeon. You focus all your time in spine. With neurosurgery, it's hard to be just spine. It's hard to be just spine. You're often doing a lot of general neurosurgery, and that comes with call. Like it's hard unless you're in a big academic program where you have specialty specific call. You're still doing hemicranies in the middle of the night. You're still doing subdurals. You're still doing shunts and things like that. And that can be, depending on your patients and depending on how you want your career to look like, that can be very aggravating. So it's hard to specialize as a neurosurgeon. It's hard. Not impossible, it's hard. So I would say what my advice is okay, where should I go? Should I go ortho or neuro? Choose a specialty that's best aligned with your career interests. Meaning, if you like the brain and the spinal cord, do neurosurgery. Forget about the 2 extra years. It's not going to matter. You're not even going to feel it. If you, well, actually 7 years plus 1 year of fellowship. If you're more interested in general ortho, like you like hips and knees and orthopedic trauma, do ortho. Okay. Don't let the years change. It's really not a big deal in the grand scheme of things. That 2 years is not going to make a difference. But I would say the main difference is that with neurosurgery, yes, it is a longer residency, but you get earlier and more predictable exposure to spine. When I was done with my neurosurgery residency, I was comfortable doing an ACDF, TLIF, laminectomy by myself with no assistant. Okay. Or no, I'm sorry, with no attending oversight. I could do that. I was very comfortable. I had a bit of unique training though. With fellowship, I was just fine tuning my skills. I didn't have too much deformity background, so I did a lot more deformity in fellowship. I was kind of picking and choosing what I wanted more experience in. Some of my co-fellows who were orthopedic surgeons did not have the same experience I had, so they were really trying to get caught up during that fellowship. These are some of the cases I did during my neurosurgery residency, which I thought were pretty cool. Just showing you here very quickly. It's not my talk. This is a patient who had cervical osteomyelitis, destruction of the vertebral bodies at 4 and 5, a little bit of 6, severe kyphotic deformity, cord compression, and this was kind of a burnt out osteomyelitis. You can see he had essentially his cervical SVA, his CBVA, all out of whack. So we did a front back on him. I thought this was a really cool case I did during residency. These were like kind of stuff I did during fellowship and now as an attending, but this was something that myself as a chief resident and a resident with attending oversight did during my chief year of residency, which I thought was awesome. And I'm like, you know, this was, showing some of my fellows in fellowship, my co-fellows, like, oh, this is stuff I did in residency, and they couldn't believe it, and I thought that was pretty cool. And this is kind of the experience you're going to get in neurosurgery residency. So this is another patient who had a severe infection of the odontoid process, prevertebral cervical abscess. You can see here, it's full of pus, the odontoid C2 all destroyed. So what we did for this one was actually we had endoscopic transnasal transpharyngeal, resected the odontoid, drained the abscess, and then posteriorly did an occiput to C4 fusion, as you can see here. So you can see just CAT scan shows you we resected the odontoid, and that was pretty cool. I had the ENT surgeon with the endoscope, and I was like holding a diamond drill bit and drilling through the odontoid anteriorly. I just thought that was a really cool case. And we did an OC fusion afterwards, and the patient did very well. Now, once you finish residency, let's say, so whether you go the orthopedic or neurosurgery route, becomes fellowship, okay? Absolutely required if you're ortho, generally required if you're neuro. Now, when it comes to the fellowships themselves, right, they come in basically 4 different flavors. And actually, I could probably add even one more here. If you're ortho, you're going to go through the spine fellowship match, which is part of the San Francisco match. So you go online, you fill out a application, you apply, you get interview invites, you go to these programs, you interview. It's literally like applying for residency over again. It's the same exact thing. If you're going through the neuro route, you can do that. You can apply through through a lot of ortho programs, or you can go kind of the backdoor route. And what I mean by that is, if you have somebody who's advocating for you, you can have they're like specific neurosurgery fellowships, spinal surgery fellowships, where you generally work with one attending, like some of the ones like Dr. Shaffrey fellowship. You can work with Dr. Baj, right? Dr. Tan. You can these are like fellowships where Dr. Shuba here at Northwell, you don't go through the San Francisco match. You apply directly and you speak with the attending and you go through that match. So that's another way of basically doing it. But in general, if you're going to kind of go with the bread and butter stuff, you have neurosurgery spine, you have orthopedic spine, you have combined neuro and ortho, which Cleveland Clinic is a good example of, and you have end-full fellowships. Now, some people, and all these are basically about a year. Now, people ask me if I did an end-full fellowship during my neurosurgery residency, do I need to do another fellowship? And the answer is maybe, but generally yes. A lot of the spine programs don't take in-full fellowships very seriously. And they expect you to generally do another year of spine. I had an in-full fellowship, or Mount Sinai, where I did my residency, has in-full fellowships, but generally we're expected to do another fellowship once you graduated. So they can be nice to get you more experience in spine, but very frequently, unless you had some very unique experience, you're expected to do another year of fellowship. This is a good time when you're in residency, when you're applying for fellowship, decide what kind of practice setting you want to be in. You want to be in a very busy urban environment like Cleveland or New York City, LA, for example, or do you want a little bit more rural environment with a different patient population, maybe more targeted cases, a little bit or less complex, maybe more like DGen, bread and butter kind of stuff. That's what you're gonna see over there. During your residency, you're gonna have an idea of what your interests are and what you would want to see. No matter where you want to go, you want to pick a high volume place. You need to get all the experience and absorb and soak in everything you can during your fellowship, because it's the last year of your life where everything you do is with oversight, and you will see how people will do things. You see how they deal with complications. You see how they deal with patients in the clinic. This is the last year, because after that, you're on your own. Like they cut the cord, you are done. You're on your own. You're expected to do everything from day one. Now, research, I say variable. Some programs are research heavy, some are not. I personally didn't think this was too important for me. Yeah, I did research during my fellowship. I didn't really see myself doing too much as an attending, so I didn't really care too much about this. Maybe you want to do more. So then this would be, this is up to you what you want to do. If you're doing a fellowship in a very busy academic center, then yeah, you'll probably expect to do some research, but I didn't think this was particularly too important. Now, the type of cases you want to get exposure to. Every fellowship is going to have a different flavor. Some are more deformity heavy, some are more like bread and butter DGen, some are like mostly tumors, if you want to do like complex tumors. you will have to decide. Some are more MIS, right? Generally, most of the fellowships are kind of like very general. You get exposures to everything, but some have a little bit more than the rest, like a little bit more deformity, a little bit more MIS, a little bit more degen, whatever. You have to pick what's more important to you. I would say, and I'm going to talk about this in another slide. If I'm going to pick the three that I think are most important and the ones that are going to be 99% of your practice, it's going to be deformity, trauma, degen. Okay. You want to be very comfortable with these three. You will bring the most value to a healthcare system, to a private practice, to a private academic, whatever, if you are very well versed and very skilled in deformity, trauma, and degen. You basically, if you can master these three, you can master 95% of what you're going to see in spine. Everything kind of falls under that umbrella. You may disagree with me, but I'll explain why in another slide. Now, sometimes people ask me about ACGME accreditation. It's required for orthopedics. It's not required for neurosurgery. As a neurosurgeon, you don't have to worry about this at all. For ortho, you want to have an ACGME accredited program. You want to, okay? It's going to be important when it comes to becoming board certified and moving forward. With neurosurgery, it's not that important. All right. So in general, there are things that you want, and then there are things that are less important, but also kind of important in terms of quality of life when it comes to the fellowship. So you want a high volume program. You want to do as many cases as possible. You just want to be just doing as many cases as possible during your fellowship. You want deformity, you want trauma, you want degen. This is 95 to 98% of your practice, okay? When you get skilled with this, then I would say you can move on to more targeted things like MIS and endoscopic, okay? You can do anything to open. You can only do some cases MIS endoscopic, okay? If you can master freehand technique or using nav and do these cases open and be good at doing these cases, you can always come and do MIS and endoscopic. It's much harder if all you do is MIS and endoscopic, it's harder to go the other way. Very rarely in a general spine practice are you going to get complex tumor intradural cases. These are few and far in between. These generally go in academic centers. They're very interesting cases. I'm not going to diminish their value. They're super important to do, but you have to ask yourself whether or not you want to specialize in this. If you do, then obviously you have to do this, right? If you don't, if you're not really seeing yourself doing sacral chordomas or these big en bloc cases, then I don't see the value in doing that, fellowship targeted that. You should probably just stick with these three: deformity, trauma, degen. This is going to be 98% of your practice when you graduate. And if you're well versed in this, you can do anything. You really can do anything. And you want a good amount of OR time, right? You really want to do a lot of OR stuff, and you also want to be in clinic. I know as a fellow, you're like, I don't want to do clinic. I never wanted to go to the clinic. I hated that. But when I look back on it now, it was actually some of the most valuable experience I ever got was the clinic time. It's so important to see how attendings deal with patients, seeing these patients post-op, the things they come up with, how attendings deal with a patient who comes in and is not doing well, right? What do you do? When to get x-rays, when to get CAT scans, when are red flags, when are not red flags, how to reassure patients, when do they do PT? Do they need a collar? Do they need a brace? When do you get a bone stem? It's like, when should you be worried, right? How do you want your clinic structured so you're not there from 9 a.m. to 11 o'clock at night, right? It's so important. It's so important. I didn't get much experience with this in residency. We had a resident clinic 1 day a week. We go there, yada, yada, yada. It was kind of BS. Fellowship during clinic was probably some of the best experience I got. And it was, when I think back on it, when I was there, I was like, oh, this stinks. I want to get out of here. I want to just be back in the OR. But when I look back at it now, it's probably the most important. It's so important to know how to treat and deal with patients, bedside manner, seeing attendings, how they dealt with complications, how they treated their patients. You could see the attendings who did well and were successful and happy were the ones who had the best bedside manner, and they knew how to treat their patients. Their patients loved them, right? And yet I dealt with attendings who were excellent surgeons, but they didn't have good bedside manner. They didn't know how to handle their patients in clinic. They get frustrated and they really struggled. They had issues. You also, less important, but also important, know how the fellowship is structured. These are questions you may want to ask during the fellowship. interviews themselves. Like, how are cases divided between the fellows and the chief residents? Because sometimes there's competition between the two. Like the chief resident may sometimes have first pick and then the fellow, right? So the chief resident getting the great cases. And then you as a fellow, you either may have to double scrub with the chief, which is not good. You don't want that. Or you may not be able to do the case, right? So it's like you should understand how cases are divided between fellows and chief residents. Also know the call schedule. How often are you gonna be on call? You want to these are important. Like you want to work hard, but you also don't want to be doing a lot of skull work as a fellow. It's pointless. You don't want to be like pulling drains and taking staples out, putting steri strips. That's not for you. You should be focused on clinic and OR. You need to learn during this time. Okay. Then the reputation of the program, that's important. But and what I mean by that is like when it comes time to get a job, which will be like around December, no, January, October, November, December of your fellowship, right? Are you gonna have attendings who are gonna step up to the plate, make some telephone calls, advocate on your behalf, and like help you get a job? Or do your attendings not care? They're like too busy doing other stuff. Like they're not, they're like kind of, yeah, they're good in the OR to teach, but they don't really help you elsewhere. Like it's important to know that. It's hard to know how. The way to figure this out is talk to the fellows who are graduating, see like what their experience was with getting jobs. Like that's the best way to do this. And see if the program hires their fellows. You want to see that. Like that's a very good sign. You know, a fellowship is going to keep people who are good and generally get rid of people who are not so good. I hate to say it that way, but it's true. You want to see the fellowship hire fellows. That's good. That's a very good sign. That means they are bringing in good people. They're training them well. They're keeping them. You don't want to lose someone who's good. It is, now that I'm on the other side of things, it is so hard to find good people. It really is. So like if you can keep people around, it's great. It's great. There's some case I did during fellowship. I just thought these were awesome. I did a lot of deformity in my fellowship, a lot of complex deformity, a lot of bread and butter degen, did a lot of trauma as well. And I feel like those three things were instrumental in my comfort level when I graduated. Because when I finished fellowship, I was ready to hit the ground running. I just wanted to do cases. I wanted to be busy from day one. I was comfortable. I didn't want to have like I just want to be like doing my own thing. I didn't want another attending in the room. I was ready for it. I had been training for this for 8 years. Like people ask me, oh, we were scared, oh, how's it feel to be attending? And no, I've been doing it for 8 years. I want this. It was the happiest day of my life to be on my own, and that's the way it should be for you. We did a lot of this was an AIS case. This was like a 18-year-old patient, or actually I think it was a little bit younger, like 16-year-old or something like that, who had idiopathic scoli, thoracic and lumbar curves. We did instrumentation and fusion on this. This is adult degen deformity with significant coronal deformity, as well as sagittal. Unfortunately, I didn't have the sagittal images here. So we did long segment instrumented fusion with laterals. I thought this was fun during my fellowship. This is a patient who had severe proximal junctional kyphosis at the top of a long instrumented construct. So we extended him up to C2. We did a PSO as well too. So this was a nice case. These were all done during my fellowship, and these were really, really cool cases that I did. This is a patient who had a very severe osteoporotic degen deformity. So we did a T4 to pelvis with a kickstand rod. I thought, these were and laterals. These were cool cases. So like, I was able in my fellowship, I was able to really like, I was comfortable doing these cases. I was just fine tuning these skills. I wasn't like staring at this and being like, oh my God, what's happening? I was really comfortable doing these cases, and I was happy to do this. Now, as an attending, all right, so you finish your residency, you finish your fellowship, you're done. Now, let's say let's rewind a little bit. You're about to get your first job as an attending, right? You're so happy. Things are great. You graduated. It's been a tough residency. It's been a tough fellowship. You're ready to get your first job. What do you do? Who do you talk to? How do you negotiate your first contract? Like, what do you do? It's just so many questions. It's scary because like you're kind of like on your own now. Because before everything was kind of like set up, and it was very, you knew, okay, you're in residency for 5 or 7 years. You finish, you can do fellowship. You finish, you become an attending, right? But what do you do as an attending? It's not easy to know, and you get a lot of different advice, and a lot of things are conflicting, and it's tough, right? And a lot of people they have very, very unique a very unique experiences that are very individual to them. It doesn't apply to you, right? So what do you do? Okay, before I get into this, any questions? I feel like I'm talking a lot here. Any questions about anything I said? You can just type it in the chat box. I don't see any questions. I'm just gonna keep going. All right. So,
Hey, John,
okay,
this is Ali. Can I ask you a question?
of course.
Hey, great, really, really nice talk. Very helpful, even for some of us, kind of quite a few years out into practice. What are your thoughts on on the neurosurgery world, the CAST fellowships, becoming more prevalent? Is it just a kind of a stamp and hey, it's a great thing to have? Is it needed, not needed? What's your take on that?
Excellent question, Ali. I should have included that in my slides as well too. So CAS fellowships are great for spine. It's excellent for them for the this fellowship to have. In particular for some of the neurosurgery only fellowships. It's just basically like a seal of approval, but I don't think that really ever mattered. I don't ever remember being asked anything about my fellowship, whether it was ACGME or CAS approved when I was applying for jobs. It was all about who you work with and who was advocating for you. It's like, oh, you're at Cleveland. Oh, did you work with Dr. Benzel and Dr. Savage? That was 10,000 times more important than the CAS designation. I don't ever remember that coming up or ever being discussed.
Got it. Very helpful.
But it's important. I mean, it's good to have. I mean, our neurosurgery spine fellowship here at Northwell just recently got CAS approved as well too. So, but at the end of the day, I think it's more important that you have, oh, you work with Dr. Shuba and Dr. Karidi than the CAS fellowship. That I think that's ultimately more important. Now, when you're applying for your first job, many different factors you need to look into here. Okay. And I'm going to go into this in more detail, but in general, I would say the most important things are going to be your location, where you're going to be. Okay. Because presumably you're going to be there for 5 years, let's say. Okay. So can you be happy where you live? If you hate the city you live in, if you hate the town you live in, that's every day for the next 5 years. It's going to be like feeling you're in a prison. You don't want to be in that situation. You need to be happy where you're at. Location. Your partners are going to be important, and that's also your relationship partner, your husband or your wife or whoever is going to be super important, super instrumental in determining your happiness at your job. They need to be happy. They need to be happy as well, right? Your kids, for example, if you have kids, this is all part of that. Your work partners, are they a good cohesive group? Are they do they work well together? Is there a lot of bickering, infighting? Do they not really, they kind of like a wolf pack in a way, like partners who kind of work together, but they don't really share cases, they don't discuss cases, they don't really talk to each other, collaborate, commingle. What's the setting of the partners? Are they happy together? Are they is it kind of utopia, or is it very dysfunctional, right? Again, at your interview day, they're always going to put their best foot forward. It's the greatest program. Everything's wonderful. We work 1 day a week. We all make $10 million a year. We're super happy, yada, yada. We all drive Bentleys, right? That's what you're going to see. But there's a lot of, every program has some issues. So it's good to see how the partners get along. What's the scope and scale of the practice you want to have? Do you want to be a complex deformity person? Do you want to be an MIS person, right? These are things you kind of want to have an idea, all right? When I first started, I wanted to do MIS. I was like an MIS, endoscopic MIS guy. And now I'm like open deformity, revision spine, flat back deformity, degen. I'm like the exact opposite of, of MIS and complex. And that like evolved over time. But interestingly enough, I was all about MIS, navigation, endoscopic, and now my practice is totally the opposite side of the spectrum. So it's interesting to see how things evolve. But I would say keep an open mind. You want to just do everything when you first start and see what you kind of evolve into. What practice setting you want to be in? You want to be academic? Do you want to be part of a faculty, working with residents, doing research? Especially generally specialty specific call can be achieved in an academic setting, right? Again, working with residents, this kind of setting, right? that, going to grand rounds, presentations, going to conferences is all academic. Now you can do the same thing in private practice too, but private practice is a different setup. You're working with partners. You generally operate not with residents. You're gonna be operating with an ACP. You're gonna be operating an AC and ambulatory spines and ASC, or private hospitals. Your contract will be different as well too, and I'll talk a little bit about that. Or you'll do private academic, which is a little bit of a mix of both. Um, uh, Most of all of these are pros and cons. You'll have to see what makes the most sense to you. I gravitated more towards academic. When I first graduated, I was like, no way, no, I want to do private, private, private. But once I kind of interviewed and I saw a lot of the private practices and their structure and their setup, and saw what some of the private practice spine surgeons were dealing with, I thought academic was more for me, and that's kind of where I settled into. And then also salary. Salary, people think, oh, it's not important, it's not important. It's important. It's not as important, but it's important. Okay. These are ways for, unfortunately, for people to get you to agree to working for less than what you're worth. Okay. That's the bottom line. When you come out, you make a lot of money for the hospital, and you should be compensated as such, because you're going to be spending a lot of time, a lot of effort into your career and into helping people, but you also need to be compensated accordingly. Okay, it's important. Not as important, but it's important. So major consideration in terms of your contract is going to be, what's your family, and I put this first because this is probably the most important. Your family situation. Do you have a wife or significant other or a husband who cannot leave, or you have a certain city? Like, sometimes your significant other is in, let's say, LA, but you're doing your fellowship in New York City, right? Can you stay in New York City and bring that person over there, or do you have to go back to LA, right? Or can you go maybe in Dallas? Like, they're different things. Can they move? Can your kids come with you if you have kids? Are you just eminently movable? Can go wherever, where the bulk of your family and your friends and family, where do they live? Do you want to be close to them, or can you move around? Do you want to make new friends? These are things you have to think about. And I think this is probably the most important. Location, that kind of falls in. I alluded to that. Again, your partners. These are people you're going to work with. This is your new family, right? You have to be able to get along with that. And it's very important. So don't discount that. Don't be like, oh, I'm just gonna do my own thing. They're not gonna get involved, whatever. No, it's super important. These people you're gonna work with every single day. You're gonna see them every single day, right? So it's super important. And then again, your starting salary. It's not as important, but it's also important. So getting to these briefly, I talked about this. What's your marital status? What do you have children that are young? Are they older, grown up? What's the situation? Can they move? Is a big deal if they need to. Where are the majority of your friends and family located? Where are you and your partner happiest? Is it in a city, in an urban area, school settings? These are all things you have to think about. Okay. And when it comes to the location, right? Are you going to be operating more at a hospital or an ASC? Does that hospital have a level 1 trauma center? And this is important, because you don't really think about asking these questions, because you're so, like, the day of the interview, when you go there, you're interviewing so many people, you meet so many faces, you're seeing all these things for the first time, presumably, right? And you like forget to ask things. A level 1 trauma center is a good and a bad thing. Okay. It's good to keep you busy. It's bad because that busyness is unpredictable. Okay. And that's tough, because yes, when you're young, it's cool. Yeah, oh yeah, I don't care. I get called in at 2 a.m. Fine, right? But like 10 years down the road, it gets old really quick. And like, do you have layers of protection there? Like, do you have people who are like competent, can give you a good exam? Because sometimes these cases are not operative. But if you don't have anyone who knows how to examine a patient at 2 o'clock in the morning on somewhere who you're kind of deciding whether or not this patient needs to go to the OR, that's not fun, because you may have to just go there and examine the patient and then decide, oh, this patient doesn't need surgery. Just imagine all that, it's tough. It's not easy to deal with a level 1 trauma center. It's not necessarily a good thing. So I don't consider that a good thing when it comes to contract negotiation. That's more of a negative to me. Residents versus ACPs. Working with residents implies that you're working with someone who has experience, as a colleague, is going to be like able to give you a good exam. Not necessarily, not always the case, because residents have different levels of training, levels of experience, yada yada. Same thing with ACPs. But with residents, it's just generally a different layer. These are people who've been through med school, have been through, a couple of years of training. It's different dealing with a resident and dealing with an ACP. Okay. So what are you going to be dealing? Who are you going to be dealing more with? You're going to be dealing more with ACPs. You're going to be dealing more with residents. Good to know. Okay. I wouldn't say it makes or breaks anything, but it's just good to know. Your partners. What's your call schedule going to look like? How often are you going to be on call? 1 week every month, every 2 months, Q6, Q7. It's important. When you start, you want to be on call as much as possible. You need to get that patient flow going. It's hard. Once you get going, you don't want to be on call all the time, right? Because eventually, it's interesting, when you first start, call is what keeps you alive. But when your practice gets on its feet and you get busy and you establish referral patterns, you have patients, you have a steady patient every week, you know how many patients you operate on, call gets old really quick and it becomes more of a nuisance. And it's hard to when you're on call and you have a busy elective schedule and you get a patient who needs surgery, it's like, how do you deal with this patient? Are you gonna have a long day? Are you gonna take them now? Can you can you do them later in the week? Can you maybe give it to one of your partners, right? And then that comes with its own difficulties. So it's important to know, how is the patient flow distributed, right? When someone calls your clinic and wants to schedule an appointment, who gets that patient, right? Is it you? Is it based on the pathology? If the patient has like a deformity problem and you're a deformity person, do you get that patient? Or does it go to whoever's on call? Or does it go to, how is the patient flow distributed, right? Is it based on insurance, right? Are you the workman's comp person? You see all the workman's comp patients. These are all things you should know, right? How are call cases distributed, right? If you're on call, do you just absorb all those cases? What if you're in a group where you're the only spine surgeon, right? If you're, let's say, you're an orthopedic surgeon and you're in a multidisciplinary group and you're the only spine surgeon, that's a tough situation because yes, you may be on call and you're getting all the spine cases, but what if your partners who don't do spine are on call and get a spine case? That means you're on call, okay? And although on paper you're on call once every Q4, if your partners are giving you their cases that they get, congratulations, you're now on call all the time, right? So, and there's no contract that says that. So you should just know, right? And what I mean by that, and that goes to my next thing, how many surgeons in your group actually do spine? Okay, you may have a spine surgeon, but that spine surgeon only does TLIFs and ACDFs. And if there's anything outside of their purveyance, they're going to give it to you because you're a new person, right? So what does that mean for you? That means you're on call all the time, okay? These are important things to know. Nobody ever talks about these things, right? It's good to know. Or are you in a group that has highly skilled surgeons and you can do all these cases? That's the best situation. But in general, when you're young and you're new, you want to be aggressive. You want to, the 3 A's, right? But you want to just take everything, right? You don't want to be turning down cases when you first start. Oh, I don't do A lifts or something. You don't want to be that, right? You just want to do everything. You want to get comfortable doing everything. So it's important to know because this will affect your lifestyle. It will directly. How involved are your partners, right? And what I mean by that is mentorship. Are they like aloof? Are they like the kind of come in, they do their cases and they bounce and they're, you see them like once in a while? Or are they like really interested in seeing you grow? Are they really interested in seeing you succeed? Are they there to mentor you? Hey, if you have one person in your life who can tell you, do this, not this, I'm telling you, and that's it. Hey, Jonathan, do this, but don't do this. You are so far ahead of the general population. I can't even, I can't even begin to tell you. So, like, how involved are they? Are they just gonna get you and just throw you out somewhere and like, hey, just figure it out on your own? Or are they gonna like mentor you? Are they gonna be there, help you out? Are they gonna give you patience? Are they gonna be like, hey, on this kind of patient, I tended to do an ALIF because of XYZ. Oh, you should have dinner with this pain surgeon or this pain doctor. They're a great source of referrals for you. You want to see these kind of cases, go have a dinner. I'll set it up for you. We'll have dinner together, right? You so want partners like this. It's hard to find, super hard to find, but it's these are things that you want. What are opportunities for you to do consulting, to invest, to become a partner in your private practice? How do you career advance? Let's say academic. How do you become an assistant professor? How do you become an associate professor? How do you get more involved? You want to have the next step. You don't want to just be stuck in stage 1 for the rest of your life. Okay. And then what's your role in the practice? This is good to ask them during interview day. Where do you see me fitting in? Are you going to be the deformity person? Are you going to be the fixer, right? Are you going to be the degen person? Oh, we need someone who can really do cervical stuff. I don't know, right? You want to kind of establish that, and you want to stick with that. It's important. Um, I'll skip this. We'll talk about that another time, but it's important. Where that comes into play, a lot of these academic environments, the Peter principle is something, if you look up anything, this is very important, right? And what that is that people are generally start and then get promoted and as they do well, they keep getting promoted and promoted and promoted until they reach a point where they're not doing so great and they're no longer qualified, right? And that's where you stay. So in theory, wherever you're at now is the area of your highest incompetence, right? You just keep going up, 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 up until you're no longer doing a good job, and that's where you stay, right? So this is key, and this is such a familiar structure in so many settings that it's good to just kind of be aware of this and see that's not in the case. This is more prevalent in academic environments, but it's good to just know that in general, right? A lot of companies are structured this way, by the way. If you look and see how these things are related, you'd be shocked at how many companies are structured this way. Anyway, so when it comes to your salary and your contract, I wanted to kind of say a couple of things here. And before I start on this, any questions? I don't see any questions in the chat box. So I'm just going to keep moving. All right. So your salary, as I said, is important, but it's not as important as the other things I talked about. Okay. And when it comes to your contract, the things you want to see is you want to make sure that you're familiar with certain things. Okay. Most of the contracts in this day and age are template. Like there's like, hey, Dr. Rasouli, this is the contract for a first year out of fellowship. Take it or leave it. We're not going to negotiate. That's the end of that. Okay. The days of, ask them for this, ask them for that, negotiate, gone. It doesn't even exist anymore. I've never seen, I mean, if it does exist, it's a very rare, unique situation. Don't count on that. Okay. Universally, every contract will have a non-compete. Some of the advice I got when I was applying as a resident, people told me, some of my more senior attendings told me, don't sign a contract with a non-compete. Oh, really? When was the last time you applied? You signed a contract, it was like 30 years ago. That doesn't exist anymore. Every contract has a non-compete. Now, with the recent legislation that passed, we'll see if that still holds. This is going to be tied up in the courts for a couple more years before it actually takes place, but this may change. So we'll see. But for now, every contract I've ever signed has been a non-compete. That may or may not be important to you. Depends on the facts of the non-compete. Now, very rarely will hospitals make any capital purchases. That being said, if you are aspiring to putting instrumentation, you need navigation, right? You need some sort of navigation platform. If the hospital has no navigation, they will have to get one for you. So that's fine. That's unique. But if they already have one and you want like the newest version, they're not going to do that. Or if you want like something that they don't already have already, it's going to be rare for them to bend anything, understand how you get paid. This is key, okay? Are you salaried? Does it matter how many patients you operate on in a year? You would make the same salary no matter what, right? Or is it more productivity contract, right? How are you going to get your bonus? Is it based on RVUs? Is it based on, how you want to understand really, really well how you make your money, okay? Very key. Because you can work super duper hard, but it may not matter at all because that's not the way your contract is structured, right? I mean, yes, it's always good to be busy. You want to be as busy as possible, but at a certain point, you need to be getting compensated. You're working for free, right? Now you're working for free. You don't want to do that. You want to be compensated appropriately to the amount of work you're putting in. It's very important, okay? And you also want to know, and this is probably the most, actually, of all these things, the most important is you want to know what happens if things go wrong, okay? And this is probably the most important stuff, is what happens if you leave? What if you just can't, you like get there, wow, this was not what I expected it to be. I need to get out of here now, okay? You need to understand what are the responsibilities and the ramifications for wanting to leave early, okay? You want to understand your liability from the contract standpoint and also your medical legal liability. And what I mean by that is malpractice insurance. And the specific wording is, do they cover your tail? Okay, tail. And that's the key word, is tail insurance. You need to have that, okay? And what that means is that you're covered even after you leave and you've been out for a couple of years, okay? So that's key, because you may leave and then like 2 years down the road, some patient you saw decides to sue you. Are you covered by that malpractice insurance? And that's tail coverage. You need to have that, okay? And you also want to have excess liability and disability, all in 401k. You want to have all that stuff too. But this is very, very key. All right. So a little bit into this, because I think this is the most important stuff. This is like the heart of my talk right here. All right. What happens when you leave? Okay. Is it clean? Like, can you just leave and, you say you give your, usually it's like a 3-month notice. So you give your 3-month notice, you leave, no problems, right? And what I mean by that is, okay, and the key things are here. Is your malpractice covered after you leave, right? Is your 401k vested after you leave? And that word vested is important, okay? Because what you can find out is that your 401k that you think you've been contributing to has been growing for the last year may not actually be yours. Your employer may have been contributing money on your behalf. And if you leave early, that money you've actually never contributed to. That money is your employer's, and they will just take it right out, right? So be aware of this. This is little things that nobody talks to you about. So I would say with your contract, it's not so much important, like, yeah, salary and all that stuff is important, right? And negotiate, oh, I want to get this. People are so focused on that, and it's so irrelevant. The stuff you want to know is what happens if things don't go well, and how you are responsible. And this is the stuff you want to know, all right? Your block time. When you start, you don't have any patience, right? They're not going to give you block time. They're not going to be like, oh, hey, Dr. Rasouli, you want to operate on, when do you want to operate? Oh, you want to operate at 7:30 a.m. on Tuesdays and Thursdays? Yeah, no problem. Yeah, we'll give it to you. Yeah, we'll move the guy who does, 3 cases, the guy who currently has that block time, and we'll give it to you. No way it's going to happen. You're going to be like 3rd start, 4th start, whatever. Operate on Saturdays, right? But you just have to eat it. That's it, right? Just do it, right? Once you get busy and start putting on those cases, and they see how you have steady flow, you're going to get that 7:30 start, and they're going to be working for you. You want those cases because they want that flow. So you need to just stomach it in the beginning, get busy, do those cases, get patients coming in, get that patient flow, start putting patients on the schedule, and that block time will come. So if they promise you block time, that may not be a good thing, by the way, because if you're not filling it, right, they're gonna be like, oh, Dr. Isley, well, we gave you this block time, you're not filling it, so we'll take it away. It's much easier. Once that gets taken away, right, that's terrible. Like, you don't want that. That's bad. Okay. Now call schedule. And I say is, can your partners do those cases, right? What is it? Okay, if you have a partner who can't do the spine cases they get on call, and it subsequently gives you those cases, that it in effect is you being on call, right? I would argue that's basically you being on call. And that's bad, because if you have vacations, if you want to do stuff on your own, right? When you're not at work, if you want to come in, if you can't live your life, right? That means you're always on call, right? So this is important. You need to know how skilled your partners are in doing spine, because if they can't do this stuff, you're going to be the one doing it, and you're going to be on call, and you're not getting reimbursed for being on call. So it's important. And that's why that falls in a trauma center. Like, if you have both, like, partners who are not comfortable doing spine and they get trauma cases, you're gonna be the one doing them. So this is very important, okay, because it directly impacts your quality of life. Your support staff, right? And what I mean by this is, like, can someone get an exam at midnight? Is someone who's rounding on your patients and giving you updates and stuff like that? If you're gonna do complex deformity, it's not even so much the clinic and the surgery itself, it's all the aftercare. And if you don't have a team who can handle these patients and deal with the stuff aftercare, it's gonna be you. You're gonna be dealing with that stuff. So congratulations, dealing with your patients in the postoperative period, also seeing patients in the clinic, also doing the surgery, also dealing with the family is here, they want to talk to the attending. These are not easy. You can't do everything. You have to have a team that can support you. And also in clinic, do you have ACPs that are shared amongst your surgeons, or do you have your own ACP who manages your practice? These are all very important things. Like, this directly impacts your quality of life, and it's not hard. It's not easy to ask about this during your contract negotiations, but you should know about this. Should I get a contract lawyer? I hear this a lot. I would say vast majority of cases, no, not really. They don't. I hired one during my negotiations. I would say that if you are getting most of these contracts are pretty much template. They're not going to change much. If you are going for a private practice that's very complicated and this and that, you may want to get a contract lawyer. But in most instances, your best bet is just to have your contract read by a fellow spine surgeon, one of your attendings, one of your mentors. I guarantee they will provide you 1,000 times better advice than any lawyer will ever provide you, and it'll be much more useful than the random, stuff that they give you. But really, as I said, the most important thing is going to be what happens when things go wrong or not as you expect. That is where the contract will matter the most. Anything else, not so much. But really, it's really when things go wrong. That's what matters the most. Now, Kruger-Dunning effect, I threw this in here, remember, and I think it's about competence, right? You really want to have competent support. You need to have it. You cannot function if you don't have good people helping you. It's so important, right? And like, I've been doing this for 20 years. That usually means they're like the most incompetent, okay? You want to have a good team. You need to have a good team. It's so important. I would say, you know what? If they give you the choice of having your own ACP versus a new NAV, get the ACP. That's going to be so important. I already kind of talked about this. Let me answer a question here. What's your advice on knowing? This is a question in the chat box. What is your advice on knowing what the culture of a particular program is, right? Yep, exactly. Most of the times when you go on interview day, they're always putting their best foot forward. Remember that. There are a couple of good things to keep in mind, okay? This is the way one was reputation. I kind of talking to other of my friends, my co-fellows, my attendings. What's the reputation of that place? Like they kind of knew what was going on. Nah, that place is shady. You don't want to go there. Or they're always fighting and competing amongst patients. They knew. So I was glad to ask them. They were very helpful. Remember, they are putting their best foot forward on interview day. Okay. If you see, and there's a saying, if you see a cockroach in plain sight, there are 10 million hiding behind the refrigerator, right? If something doesn't seem right to you, go with your gut. If something doesn't seem right to you on interview day, remember, that's the best day. They're trying to show you their best, right? That's goes to show that probably things are wrong. You pull back that curtain, you see 10,000 wrong things. Go another time, right? Tell them, hey, I love your program, da da da. I just didn't get a chance to really get a good feel for it. Go another time if you can, right? Ask around, like I said, and then see. Usually they'll take you to a dinner. Most of these interviews will take you to a dinner or a lunch or something, right? Do the partners come and they meet you? Hey, Dr. Rasouli, or Jonathan, great to meet you. I'm so and so. We heard about you coming, very excited. The partners, a couple of these interviews I went on, I met all the partners that day. They like introduced me. Some of the interviews I just met one guy, and yeah, I didn't meet anybody else. So that was a red flag, I didn't like that at all. I'm about to run out of time. Okay, so I just want to go through this quickly. Remember, 50% of certain, these are some statistics. 50% of certain leave their first job. I've actually fell into that category. But that was more of that was my situation was a little bit unique. I had COVID to deal with. I was in the heart of COVID. I wanted to go back to New York City anyway. I'll talk about it another time. And then within 5 years, nearly 70% of people leave their first job. Okay, so just keep that in mind. It's not a big deal. You're not in resident anymore. If you need to leave, you should leave. That's it. You are responsible for your own career. Yeah, it's going to piss off some people. Fine. They'll get over it. They'll hire somebody else. Okay. Bottom line, you're not stuck anywhere. If you need to go, you should go. That's it. I highly, if you're not happy, you should not stay in a place you're not happy. You're going to be miserable. It's going to affect every aspect of your life. Do what's right for you. The day you leave, they'll have a little pizza party. They'll cry a little bit. The next day, forgot about you as if nothing happened. So don't think you're that special. If you need to leave and you're not happy, you should do that. Okay. And this falls into like the rest of your life. Remember, you're going to have to deal with boards. You're going to have to deal with your family, build a family, advance your career, and finding happiness and purpose in your career. Because for the first time in your entire life, like it's not so structured anymore. Your entire life, for the most part, was take a test, pass, graduate, move on to the next grade, then get into college, then get into med school, then find a specialty, then get into your residency, then get into fellowship, then find a job. Now you got your job. Now you have nothing more to look forward to in terms of that kind of advancement. You need to find your purpose. You need to find happiness in where you are. And it can be hard to do. It's this weird nebulous space that you're in. It's easy to get burned out. So this is the key. This is what I would say is the key. And I hit on a lot of things today. Maybe we should have another talk about this stuff. We can talk more in depth. You maybe email me some of your questions and we can talk about this kind of stuff. But this is really, 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 really the key. Okay. So I would say, and this is what ChatGPT's answer was to this, circling back around. So what sets the journey of spine surgeon apart? I actually give a concise answer to this, right? And this is what they said. I don't think it's very concise. You can read this for yourself. But all right, any more questions? We're a little bit. Oh no, actually, we're 5 minutes. So, um, any questions? If you have any, um, it might be difficult, or maybe if there are any, someone wants to talk to me privately, I'm just gonna type my email in the chat box. You can email me anytime. I'm more than happy to give any advice on my own path, on my journey. I recently went through the process myself, and I did it twice actually. So I'm more than happy to answer any questions for you guys. So hopefully this helped. And yeah, just let me know. And I wish you all good luck and great success in your careers. And I hope you all have a very, very good night.